Good evening, all. Welcome to the fifth session of vertical integration. So this time we have selected a topic which is we have got very much clinical importance as well. So we have going to discuss regarding malaria. So we have an eminent faculty. To my right, we have Giri sir, who is the principal and also the professor of emergency medicine here. And we have Dr. Sri Lakshmi here from Department of Community Medicine. And we have Dr. Nandita from Department of Microbiology and Dr. Aruna from Department of Pathology. So welcome each one of you for the vertical integration session. So as we does usually, we have divided few questions, and depending upon that we will discuss. If we have anything else that you need to add on, please go ahead and add that to the discussion part. So first, the most important one, we will start with the community medicine department. Ma'am, can you just briefly go ahead and explain regarding the epidemiology of malaria?
Sure, sir. So when we say about epidemiology, what we usually mean is the distribution of diseases globally in a region, in a country, and also in the place where we stay. So when we look at malaria, if we look at the World Malaria Report from 2021, around 247 million cases and approximately 619,000 deaths are attributed to malaria alone annually every year on a global perspective. When we look at India, 17% of these global cases and approximately 1.2% of the deaths reported from malaria occur in India. Okay. But the larger share, 95% and 96% of the mortality and the case burden is borne by the WHO South African region. Oh. With the COVID pandemic, what happened is most activities with regard to malaria got stalled, and we had around 13 million additional cases and approximately 63,000 deaths being reported due to malaria interruption, service interruption. So that is with regard to the epidemiology.
So when you speak about what are the most important thing being in India, so which you think that this area has got the maximum incidence of malaria that has been reported?
So malaria, when we look at malaria, there are certain risk groups for malaria. So mainly for most diseases, children are the highest risk group. Okay. In malaria, they are at a higher risk because they have not developed the immunity to malaria in stable transmission areas. The next groups will include non-immune pregnant women, who are again in high transmission areas.
Fine. That's I got it. Okay. So with that will be the overall epidemiology that you have covered. And yes. Ma'am, from pathology, can you, when we say about pathology, the first question that arises, pathogenesis of malaria. Yeah. Can you just give a briefing about the same?
Yeah, of course. Yeah. So as we all know, the definitive host for the malaria is a female Anopheles mosquito, which usually feeds on the human blood. So when the malaria bites a human, the sporozoite, which is actually the infective form of the parasite, that is transferred to the circulation. It travels in the peripheral circulation to reach the hepatocyte or the liver cell. So this sporozoite, they have got certain adhesion molecule or certain proteins on the surface. To name a few, that there is a circumsporozoite protein, and another one is thrombosporin related adhesion molecule. So with the help of these molecules, the parasite or the sporozoite form, they get attached to the surface of the hepatocyte, and thus they gain entry into the hepatocyte. So what happens inside the hepatocyte is, these sporozoite, they undergo nuclear division, and into which they turn into what is known as the schizont. So the schizont, with an incubation period of 1 to 4 weeks, they mature and thus forms the merozoite. So because of this, the hepatocyte enlarges and finally it gives way, releasing the merozoites in the circulation. So basically the sporozoites, depending on the species of Plasmodium, they are of two types. So one is an active one, which multiplies or divides into a schizont, and the other one, which is a dormant form, which is known as the hypnozoites. So basically in the Plasmodium vivax as well as in the ovale, these dormant forms, they remain as uninucleate forms. They don't divide. So what happens after a longer time, or when the immunity of the patient gets compromised, some of these forms get again activated. They get converted to the schizone, and they again causes the relapse of symptoms, which are the proposed pathogenesis behind the relapse in case of Plasmodium vivax and the ovale. But when we take the falciparum as well as the Plasmodium malariae, there is no hypnozoate stage, but in those species, the erythrocyte forms itself persist for some amount of time, and later on they get multiplied to get a significant number, again resulting in varying clinical presentation. So this is known as short relapse or the recrudescence. So now we have the merozoites which are released from the hepatocyte. Those merozoites, they have got again some Lewis-like glycoproteins on the surface, which again attaches to the glycophorin. Glycophorins are basically transmembrane proteins on the surface of the erythrocyte. With the help of that, they actually get endocytosed into the RBCs, and the RBC membrane, it gets seals off by itself and forming a digestive vacuole. So basically this digestive vacuole is having the merozoite which is gaining entry into the RBCs. So once they get entry into the RBC, usually their merozoites are basically spindle forms. So now they get rounded up, they loses all their internal organs, and they have a central vacuole. The cytoplasm will be pushed to the periphery, and the nucleus will be placed at the one pole. So this young form of the parasite is known as the ring forms. So basically when we stain a smear with any of the Romanowski stain, the cytoplasm will be stained as blue and the nucleus will be red. So this is actually the ring form. Now the ring form, the parasite actually feeds on the hemoglobin inside the RBCs, but it won't metabolize it completely. So it actually leaves a residue, that is the hematin globin pigment. Previously this was known as the hemozoin pigment, otherwise known as the malarial pigment. So now this ring form is slowly enlarges, and they have got some amoeboid movement, and the early amoeboid form is called a ring form, and the later ones are known as a late trophozoite. So the late trophozoite, there is no nuclear division, and once the nuclear division starts, we may call it as a schizone. So this schizone can have now two pathways. One is some of them can differentiate into the gametocyte, which actually begins the sexual cycle when another Anopheles mosquito feeds on the again blood meal, but some of them again differentiate into schizones. So depending upon the species, actually the Plasmodium falciparum, it has got a specific adhesion molecule on the surface which is known as Plasmodium falciparum erythrocyte membrane protein, or PFEMP1. So with the help of these protein, they get attached to the adhesion molecules on the endothelium, that is the intracellular cell adhesion molecule, or otherwise known as ICAM, or VCAM, vascular cell adhesion molecules, because normally we know RBCs have got the negative charge, so they normally don't interact with the endothelial cell, but because of the presence of this EMP1 protein, they get concentrated on the surface of RBCs as knobs. So because of this, they get adhered to the endothelium, resulting in the arrest of these RBCs in the capillaries. So thereby the parasitized RBCs block the capillaries, resulting in tissue ischemia and further damage. So now the merozoites, as they mature, they causes a rupture of RBCs, releasing number of endogenous pyrogens, for example mostly the cytokines, in response to the either a merozoite or the ruptured RBC fragments, again causing the clinical features like rise in temperature. They also causes release of reactive oxygen species, which may again causes tissue damage, and they also causes decreased production of RBC, again resulting in anemia.
Thank you, ma'am. So that was quite elaborate. What you have covered regarding pathogenesis. Just put your headphones and listen to this So that is what all about the pathogenesis of malaria. I think it's one of the most important questions that they can
Yes, sir.
anticipate
Yes,
for your exam
yes.
also. Thank you for that, Albert. I know there can be a little bit overlap from what she has said
Yeah,
for the
yes,
next
sir.
question.
Yes,
Basically, the life cycle of a malarial parasite. Over to Dr. Nandita. Can you just briefly tell us, because there was, I'm sure there could going to be some overlap with whatever she has said. Can you just elaborate it, ma'am, that again?
The malarial parasite has two hosts, the definitive and the intermediate host. The definitive host is where the sexual cycle takes place, and that is the female Anopheles mosquito. The intermediate host is where the asexual cycle or schizogony takes place. That occurs in man. So the cycle in man begins when the mosquito bites and sporozoites are deposited. They enter the circulation, reach the liver, and undergo pre-erythrocytic schizogony. So the sporozoites differentiate into trophozoites, and then they form schizons. And then the hepatocyte ruptures to release merozoites. So these merozoites, once they enter the circulation, will infect erythrocytes. So the cycle that occurs in the erythrocytes is called erythrocytic schizogony. So within the erythrocyte, as she described, they go through the stages of the ring form, late trophozoite, and then the schizont. Then the RBC ruptures to release merozoites, and these merozoites, some of them will be killed by the immune response. A few others will infect other RBCs. So repeated cycles of schizogony takes place until some of these parasites develop into gametocytes. So when a mosquito bites an individual who harbors these gametocytes, the gametocytes are called microgametocyte and macrogametocyte. The male is called the microgametocyte. The female gametocyte is called the macrogametocyte. So when the female Anopheles mosquito bites an infected person, it ingests these gametocytes. So within the gut of the mosquito, the male gametocyte, the microgametocyte, its nucleus divides and it exflagellates. That is, it divides into 8 flagellated forms called microgametes. And the female gametocyte or the macrogametocyte also develops into a macrogamete. So these microgametes, they fuse with the macrogamete, fertilization occurs, and the product of fertilization is a zygote. So the zygote then, it becomes elongated and motile. It develops into a form called the ookinete. And this ookinete stage penetrates the midgut wall of the mosquito. So once it penetrates, then it encysts. It develops a thin membrane around itself, and it forms an oocyst. So the oocyst enlarges. There are many oocysts found within the midgut, and these oocysts, they undergo sporogony. So within the oocyst, a large number of sporozoites, hundreds of thousands of sporozoites are formed, elongated forms, these sporozoites. Once the oocyst matures, it ruptures, and the sporozoites are released into the hemolymph of the mosquito, and some of them migrate to the salivary gland. So a female Anopheles mosquito with a salivary gland that contains these sporozoites is infective when it bites a human being.
Okay, thank you, ma'am. Thank you, ma'am, for that discussion. Now to Giri, sir. Sir, can you just briefly tell us the clinical features of malaria, sir?
So when we discuss about malarial clinical feature, as a clinician, I can tell it is very difficult to make a clinical diagnosis of malaria in emergency room or in your clinic, because that mimics almost all other diseases. Like it can be like dengue fever, same clinical feature, leptospira, same clinical feature. But book says that if you read books, it says that every 3 day or 4th day you are getting fever, patient will have high degree temperature, chills, all these things, madam told. It is because of the release of the organism from the ruptured RBCs. But when we take paracetamol, it is not going to happen. Every day when you are taking paracetamol, it is not going to happen. But even then, for an MBBS student, most of the malarial parasites will have every 3rd day or 4th day high degree fever, chills, rigors. They all happens because this parasite enters inside the RBC and grow up there and break the RBC, release a lot of immune-mediated substances. They create all this problem. So fever is the most important thing that occurs every third day, fourth day. But if you see the falciparum infection, it is not like that. Any day, any time, patient can have fever. That is because that affects almost all types of RBCs, young RBC, old RBC. All these things are affected by them. So that is a different situation in falciparum malaria. But other things, you have periodic fever. That is the most important thing. Then if you see falciparum malaria, because madam has already told cytoadherence, that is a feature of falciparum malaria. They enter inside RBC and they try to produce adherence of RBCs to the wall of the blood vessels or to other RBCs. They produce block everywhere. Microcirculation block can happen. So patient can have altered behavior, seizure, myocardial infarction, hepatitis, liver, kidney disease, ARDS. So many problems can be produced by falciparum, but that they are not seen in a patient who is having Vivax infection. So these are the main clinical feature. But if you see the falciparum, you can get sometimes very florid presentation like ARDS. So ARDS is not explained in other Vivax or other things. So ARDS can also be due to this microcirculation block and fluid from the blood vessels can come to alveoli, and alveoli are something it mimics like pneumonia. So many complications are mainly due to this cytoadherence. That is a problem in malaria. Other things are like any other fever. You can have 1 or 2 days fever. Then after that, some patients, since we are seeing patients in endemic area, they may not have this much symptoms. They have 1 or 2 days fever. Then the fever may subside for a long time. Again, it can come. So that also can happen. But mainly for an MBBS students, it is fever, chills, rigors, occurs every third day or fourth day. In falciparum, any day it can come. It may not respond to your routine paracetamol tablet. These are the main clinical features.
Thank you, sir. Thank you, sir, that overview. Now, over to Dr. Sri Lakshmi again. I have interrupted you in between when the question was asked. So, I'll ask it again. These groups of malaria. So,
Thank you, sir. So the risk groups, like I was saying, the highest risk group is definitely children because they don't have the protective immunity. Apart from children, we do have non-immune pregnant women, people who are affected with HIV or AIDS, non-immune pregnant women with HIV and AIDS, then travelers who travel from non-endemic to endemic regions, they don't have the protective immunity. One of the other risk group is the migrant families and their children. When they travel back from a non-endemic area back to their city, which is endemic, they are at higher risk because their immunity might have decreased or absent at times. In India, when we look at it, we do have a high number of cases being reported from tribal areas, in rural areas where they don't have access to healthcare, or in regions where there are inadequate control measures. In these regions also, we have a higher risk of malaria.
okay. So that will be the young population, and
Yes.
those who are all HIV positive, they are all at high risk of developing
risk
the
of them.
complications. So we can call it as a high risk group.
They are the high risk group.
Okay.
In the WHO South African region, 85% of the deaths are among children.
Okay. Okay.
So they are definitely the highest risk.
High risk. Okay. Thank you for that. Now back to ma'am again, and ma'am, can you just briefly, Dr. Arnab from pathology, can just briefly tell us the usage of peripheral smear bar QBC for MP? That was one of the investigation that when we are studying that one of the most important investigation that you should do. Can you just brief about these two investigations, how useful it is, and how ideally we should be doing this?
Yes, thank you. So the essential method for a definitive diagnosis of malaria is basically depends on the picking up of a malarial parasite in a peripheral blood film, and then we have to identify which species is it by looking into the finer morphological details. So basically peripheral smear, we have a thick smear and a thin smear. So thin smear, as we all know, this is a routine peripheral smear that we do as in case of any other hematological disorder. So thick smear, basically how we are doing is actually we have to take 3 to 4 drops of blood on a glass slide. So we spread it into an area of like 1.5 to 2 centimeter, and we have to dehemoglobinize it. So actually tick smear is actually thick layer of lysed RBCs. So we have to dehemoglobinize it by just dipping it into the water so that the RBCs get lysed. Then we have to stain it and then dry and then examine under the microscope. So that is a thick smear. So the most sensitive method is actually examining the thick smear whenever we have a facility of a microscopy. So thick smear we have to examine initially along the edges of the smear and then go into the center or the other parts of the smear. So in case of this Plasmodium falciparum, actually it is very important to mention the percentage of parasitized cells to know how much is the severity of the malaria. So how to find out the parasitized cell is, we can give the percentage. That means by counting 1000 RBCs, so in that 1000 RBC, how many RBCs are infected, then you have to convert it into a proportion. So for example, if we have 30 RBCs which are infected among the 1000, the proportion will be coming to 3%. Then we also have another index, that is the parasite density index. That actually we have two methods. One is already a generalized formula, that what is the formula is number of parasitized cells divided by total number of WBCs into 8000. 8000 is actually a constant, or we can also give it like 1 plus 2 plus 3 plus. So 1 plus is actually the 1 to 10 asexual forms per 100 high power field in a thick field. Because the morphology, even though we get it in a thin smear, the chances of picking up a parasite is always more in a thick smear, because the sensitivity is actually 5 to 10 parasite per microliter. So it's always easy, or if you have to start examining the peripheral smear from thick, then you can go to the thin smear. So 2 plus will be 11 to 100 per 100 high power field, and 3 plus will be 1 to 10 per high power field in a thick smear, and 4 plus will be more than 11. And it is actually according to WHO guidelines, they say that we have to examine at least 100 high power field before declaring a smear to be negative. And also the smears have to be prepared ideally within 3 to 4 hours, because once we keep it delaying, the morphology of these species may be varied and it will be difficult to identify the species. So in the peripheral smear itself, how are we going to identify these species? So basically, as ma'am has also described, the parasite has got basically 4 forms. So we know the ring forms. There is a trophozoid form, which is actually the growing form, where the pigments also start to come out. Then you have the asexual dividing form, that is a schizone, and the sexual form, that is a gametocyte. So I'll quickly brief out how we identify these species. So first is a Plasmodium vivax. So Plasmodium vivax, actually it infects young RBCs or the reticulocytes, and we can see all these forms of the parasites in the peripheral blood film in case of a Plasmodium vivax. So the ring forms in the Plasmodium vivax will be, they are large and they have got single chromatin dot, and the late trophozoite is again, they show some amoeboid motility, they are compact, and when we come into the pigment, it is a fine granular yellow brown pigment, and the gametocyte is also spherical in shape. So in the Plasmodium ovale also the same thing, that is because it infects the reticulocytes or the young RBCs. Again we can see all the forms in the peripheral blood film. The ring forms also, they are almost similar to vivax, but they are smaller in size. Late schizone also similar morphology, but comparing to the vivax it is small, and gametocyte is also, it is spherical and compact. And the malarial pigment, the color is actually, they are brown, but they are more coarser than the vivax. So without the picture it is difficult to appreciate, but still I'll just brief it out. So for the Plasmodium falciparum, as sir has already explained, they infect all the stages of RBCs, but they have got slight predilection to younger ones, but they infect all the stages. This is why the falciparum malaria always presents with complications like massive hemolysis and other complications. And the ring form, the specialities, they are thinner ones, but they have multiple chromatin dots, and you can even get multiple ring forms in a single RBC. And also the gametocyte, they are crescent shaped or banana shaped, and the pigment color is dark brown or they are black in color. And the last one, the Plasmodium malariae, unlike all other species, they infect older ones. And the size of the infected cells, they remain normal in falciparum and in the malariae, but they enlarges in vivax and the ovale. And the ring forms also, they are small and compact, and gametocyte also, they are compact, small, filling almost up to the 2/3 of the cell. So these are the features with which we can identify the species of malaria. Now very briefly about the quantitative Buffy code. Actually this is again a screening test to pick up the malarial parasite, but we are not routinely doing it because we always need a fluorescent microscopy to pick up these parasites. So what is the procedure is, we are taking a small amount of blood that is being centrifuged in the QBC centrifuge for 5 minutes, and that capillary tube we have to pre-coat it with acridine orange, which is actually a fluorescent dye. So this acridine orange binds to both DNA as well as RNA. So if at all any parasite is present in the RBC, it binds to nucleus as well as the cytoplasm, and they show red and green fluorescence when we view under the fluorescent microscopy at a wavelength of 460 nanometer, but it's not being widely used. Still the gold standard is our peripheral blood film.
Thank you, ma'am, for that elaborate explanation. Now, since we have heard a lot of vivax, a lot of malaria, can you briefly, ma'am, describe the different types of malarial parasite and what are the clinical relevance for these different types?
So, classically, 4 species of malarial parasite have been described to infect humans. Now there's a 5th species. So, the 4 species are Plasmodium vivax, falciparum, ovale, and malaria. The 5th species is a pathogen of monkeys called Plasmodium knowlesi, which has been described to cause disease in humans in areas like Malaysia, Singapore, Philippines, Vietnam, Thailand, etc. So, the importance of speciating. Plasmodium falciparum causes the most severe disease for reasons that she's already described. So the periodicity of fever, although it is not, it's classically described, it's not, it may not be practically seen. The periodicity of fever is once in 48 hours for Plasmodium falciparum, Plasmodium vivax, and Plasmodium ovale. In Plasmodium malaria, it is once in 72 hours. So, so Plasmodium falciparum, vivax and ovale, they cause tertian malaria, whereas Plasmodium malariae causes quartan malaria. And the new species Plasmodium knowlesi, it causes quotidian malaria. The periodicity is every 24 hours. So Plasmodium falciparum, since it causes the most severe disease, it's described as malignant tertian malaria, whereas vivax and ovale, they cause benign tertian malaria, and Plasmodium malariae causes quartan malaria. So Plasmodium falciparum infects RBCs of all ages. Plasmodium vivax and ovale tend to infect younger RBCs or reticulocytes. Plasmodium malariae tends to infect older RBCs. The size of the RBCs also vary. So in Plasmodium falciparum, the size of the RBC is normocytic, it remains the same. Similarly for Plasmodium malaria also, it is normocytic or slightly smaller. Plasmodium knowlesi also infects RBCs of all ages, and the size of the RBC remains the same. Whereas for Plasmodium vivax and ovale, the size of the RBC is slightly enlarged when you view it on peripheral smear. So the differences in microscopy, she's already described.
Ma'am,
So,
what is the new species, ma'am? Can you just spell
Plasmodium knowlesi.
that? Can you just spell that, ma'am?
Knowlesi.
Okay. That's the newer, since last 3-4 years it has been reported, or much more than that? Okay. Thank you. Thank you, ma'am. Over to Giri sir. Sir, can you just briefly tell regarding complicated malaria?
Okay. So when we discuss about malaria, clinically only there are two types of malaria. Madam has told 5 types are there, but clinically only 2 types are there. One is complicated, other one is non-complicated or benign. Benign, whatever Madam told, all other species other than falciparum, it is benign. Falciparum malaria is always complicated. There are 2 important reasons for that complications in that type of patients. One is cytoadherence, that is all RBCs are stick together and produce microcirculation block. And other thing is, like Madam told, it can affect all the ages of RBCs. So when it affects all the stages of RBC, you can imagine that how much hemolysis can occur in human body. So hemolysis is the major feature for any malaria, like fever, chills, all these things are clinical findings, but when you see the signs, jaundice is the major problem. Jaundice is because of hemolysis. That is maximum in falciparum malaria, and it is minimal in other types of malaria. And there are other reasons for jaundice also, because liver can be involved. When the microcirculation block can happen, it can occur everywhere in your body. So liver injury also can happen. And malaria is falciparum malaria is one condition where the kidneys are involved, whereas vivax malaria, kidneys are not normally involved, but in later stages of severe vivax malaria also it can happen because of the later complications. But here again, cytoadherence and block in the microcirculation, kidneys are involved. And another important problem, if you follow up malaria cases, you can understand that patient can have altered behavior, seizure, malarial coma. All these things are very, very common in falciparum malaria. So falciparum malaria is most complicated malaria among all the malarias, and some patients can simply present with ARDS. It can mimic a pneumonia also. Patient will have high degree fever, chills, rigors. When you take an X-ray, you can see multiple shadows all over the chest X-ray. That can just mimic a viral pneumonia also. So there are a lot of different complications. All these things are due to this cytoadherence, and it affects a maximum number of RBCs. So complicated malaria means nothing but it is only a falciparum malaria, where all other malarias are benign malarias. So same like Madam told, HIV infection is one of the most important problem because in African countries and all, main problem in them is a falciparum malaria and HIV infection. Other problem is many of these malaria cases are always like they are associated with gram-negative sepsis. That also can add to this problem. And pregnancy is also another problem, because many of the drugs which was given in the past, what was not used, was producing problem in a pregnant lady. So all these things are the complications of malaria, and for an MBBS student, complicated malaria is nothing but a falciparum malaria.
Thank you, sir. Dr. Lakshmi, can you just, when you say about the most important reason, you definitely should do the preventive aspects. So can you just give an overview regarding the preventive aspect and the control measures that has been taken for malaria, the national programs, if any, if you can list that, it will be.
So I'll start off with the last part of that question, the national program. The national program for malaria was the National Malaria Control Program, and it was launched in the year 1953. So it is one of the oldest national programs on the planet, in India. So this was renamed as a National Vector-Borne Disease Control Program in 2002 with a 3-pronged strategy. The strategies included early identification and surveillance of malaria, epidemic preparedness and response, then integrated vector management and supportive intervention measures. So the supportive intervention measures include things like behavior change communication, capacity building, intersectoral collaboration, monitoring and evaluating the works done for malaria and all that. So one of the things that I mentioned as this, as one part of the strategy is the integrated vector management. So that is actually the active intervention measures that we take for prevention and control of malaria. Integrated vector management is an approach which implements all vector control strategies with or without the use of insecticides to basically decrease the vector population, thereby decreasing the human vector contact and managing insecticide resistance. So in integrated vector management, we have 2 things. One is we have the anti-larval measures and the anti-adult measures. In the anti-larval measures, it is again divided into 2. One being the use of larvicides, like use of oil-based products on water bodies or Paris green as a insecticide. The other component of anti-larval measure is the source reduction Source reduction are all the activities that we do to reduce the breeding of mosquitoes. So that will include drainage of water collections, filling water bodies, also observing dry day in the community. So now we have, initially it was just one day when we observed dry day. Now every week there are 3 different days allocated for institutions. So on Sundays we are supposed to observe dry day at our home. On Saturdays it is in institutions, and on Fridays schools are supposed to observe dry day. So those are the anti-larval measures. And when we come to the anti-adult measures, we have the residual spraying using malathion or fenthion. We have space sprays wherein we can do thermal fogging, wet fogging and all that. And the personal prophylaxis measures, which will include use of repellents, creams, mosquito coils, insecticide-treated bed nets, and also the large-scale screening of doors and windows. Under the NVBD-CP, there are 6 diseases, of which one is malaria. So for malaria, the national targets or goals will be, for 2030, will be 0 indigenous cases of malaria throughout the country and elimination of transmission of malaria, along with maintaining interruption, in areas where they have interrupted transmission, to maintain that status. So these are the prevention strategies for malaria control.
Thank you, ma'am. Now to Nanjira ma'am, I've just, we have gone through the peripheral smear, thick smear. Do we have anything else to offer in microbiological laboratory investigation for the diagnosis of malaria? What is the gold standard if you say maybe a peripheral smear might take some time, all centers we will not get it immediately. So you have something else that for the diagnosis of malaria, ma'am?
Microscopy itself, there are peripheral blood films. Then there are fluorescent stains like actinic orange stain, the Kawamoto technique, and then there is QBC, which you described, quantitative Buffy coat. So that requires a microscope, and it requires some expertise on the part of the person who's examining the smears. The other modality is antigen detection. So there are antigen detection tests which can target antigens like histidine-rich protein 2 in Plasmodium falciparum and parasite lactate dehydrogenase and aldolase. Okay. So these antigen detection tests, they are rapid. So within 15 to 20 minutes, you have a result. They also do not require any equipment or training. Those are the advantages. So there are different types of antigen detection tests. So most of them detect Plasmodium falciparum and malarial parasite as a genus. So most of them have different bands. So there's a control band which should always be present for the test to be taken as valid. And apart from the control band, one other band should be present for the test to be declared positive. So the 2 bands, one will be usually for Plasmodium falciparum. So it will have a capture antibody which will target one of the antigens of Plasmodium falciparum, which could be either HRP2 or the Plasmodium falciparum specific LDH. There is usually another band which is capture antibodies against pan-malarial LDH or aldolase. Okay. So there are also some ICTs which can, that is immunochromatographic tests or rapid diagnostic tests, which can detect Plasmodium falciparum and Plasmodium vivax separately, and the pan-malarial band. But it is not possible to differentiate Plasmodium ovale and Plasmodium malariae, and none of the antigen detection tests can detect Plasmodium knowlesi. Okay. So those are the antigen detection tests. The disadvantages are, of course, they're not as sensitive as, say, a thick smear. So at least they have a limit of detection of around 100 parasites per microliter. Below that, their sensitivity varies. It's not reliable. 100 to 200 parasites per microliter. And there can also be false positive tests in case of autoantibodies, like where there's a rheumatoid factor. So those are the disadvantages. And apart from antigen detection, there's also culture which is done only for research purposes. That is done by culturing the parasite in RPMI 1640. the Traeger and Jensen medium, not done in routine laboratories. And apart from that, the most sensitive method now for detection of malaria is PCR. So PCR usually targeting the 18S rRNA gene. PCR is extremely sensitive, can detect 5 parasites per microliter or less. It can also speciate. It can detect the different species of malaria, and it can also detect drug resistance genes, for example. Then there are other methods of detection, molecular methods like loop-mediated isothermal amplification, LAMP, which is not very widely available but also very sensitive. And apart from that, there are methods like digital cytometry, which are not standardized and not widely used.
So if you say the gold standard investigation will be PCR. So like for any investigation, any infection, gold standard will be PCR. Okay. So the NOLIS we can, will be able to...
NOLIS, yes.
Yes, we can.
Target.
Are we able to do it in our institute? We'll be able to...
We've not tried. It's not present in India.
India. So, okay, fine. Thank you, ma'am. So next over to the pathology, ma'am. Again, we have an most important thing is we all have discussed regarding the complication. Can you just brief out what are the common hematological and other complications that we need to anticipate in case of malaria?
So I'll just list out from the pathological perspective. So hematological complication, as we know, we have already discussed. One is anemia, which is mainly hemolytic, and the microscopy shows normocytic normochromic anemia. Then second is massive intravascular hemolysis, where the patient present with hemoglobinemia and hemoglobinuria. So this is a part of a syndrome known as black water fever. So where the patient has fatigue, prostration, fever followed by massive hemolysis. So other than hematological, we have tropical splenomegaly syndrome, which is also known as hyperactive splenomegaly syndrome, which is basically an altered immune response to the malarial parasite, where the patient presents with massive splenomegaly. They have high titers of anti-malarial antibody, but we may not be able to pick out the parasite in the peripheral smear. So other features including reduced C3, hypergammaglobulinemia, and these patients, they do not respond to either anti-helminthics or the iron supplements when we give for anemia. So then another important complication is splenomegaly. So the spleen can enlarge to a size and they weigh more than 1 kg, and initially there will be congestion, so the spleen is soft enlargement. Later on it become thick, brittle, fibrous, and we typically describe pathologically as ague cake appearance, and even this can go into brittle and splenic rupture. And finally, the cerebral complication. So there will be congestion of the meninges, the brain, there will be occlusion of the capillaries, and also there will be multiple petechial hemorrhages with peripheral glial reaction, which we describe as malarial granuloma or dark granuloma, and these are usually seen around the occluded capillary. So these are the some of the complication with pathological features.
Thank you, ma'am. And to Giri sir, can you just briefly tell us? I know it's a big question regarding the management of malaria, both complicated and uncomplicated.
So when we discuss about management, we have to think the previous generation drugs also, because for an MBBS student, when they are writing an essay, they need to know what was a drug which was used in the past. That is, chloroquine was the drug of choice previously, but now we know that it is resistant to most of the areas in India. Chloroquine resistance is well known, so we are not using chloroquine, but even then chloroquine had some advantage that all students must know, because it's an anti-inflammatory drug. When you give chloroquine 6 tablets, immediately fever will subside, whatever may be the fever. That was one of the advantage for chloroquine, but the problem is it is resistant, so it is not nowadays used. Then next drug came was quinine. Quinine was very useful drug which was not very safe in pregnancy, but it has got a very good action on most of the types of malaria, including falciparum. Now that also resistant. If you see the treatment protocol, 10 milligram per kg body weight should be added to dextrose infusion and to be given, because quinine is one drug which is same like insulin. It can produce hypoglycemia. So both quinine and malarial parasite can produce hypoglycemia. So quinine used to be given in a infusion of dextrose solution, and after 4 hours we used to continue dextrose even in that patient, because anytime this patient can go to hypoglycemia. There are multiple reasons. One is quinine, another one is falciparum malaria, third one is liver injury. All these things can produce hypoglycemia in a malaria patient. So again, quinine is also resistant resistant for malaria nowadays. So next drug was artesunate. It's a Kunghasu derivative. It's a Chinese herbal drug. Now we are using artesunate. There are different types of drugs. Artesunate is there, arteether is there, artemether is there. They all are safe even in pregnancy. So nowadays we are using artesunate for all types of complicated malaria. We are not even trying other types of drugs because this is freely available and there is no resistance documented so far in malarial cases. So that is a treatment option, but we always try to add. Suppose you have a patient with malaria with some sort of infection other than malarial infection, procalcitonin is high. We always add a gram-negative coverage along with the malarial treatment because we know that most of the malarias are somehow they are associated with gram-negative sepsis and septic shock. So we always try to add drugs like ceftriaxone along with malarial treatment. And sometimes we can even think about resistant malaria to even to this molecule. So nowadays some experts says that you add two drugs. One is your artesunate with the doxycycline. We don't know exactly whether it is useful or not. There are no major studies regarding that. But even then many doctors add artesunate with doxycycline. But theoretically it has got no major supportive evidence for that. But even then many doctors use it. So that is a treatment for malaria. Three important drugs, chloroquine, that is resistant, quinine, that is resistant, now artesunate. Quinine, when you discuss, there is another important problem when we are giving quinine. It can produce cardiac problem, arrhythmias. That's why nowadays we are not using quinine at all. Even many malaria cases, it may be beneficial, but we are not using because it can produce sometimes arrhythmia, dangerous arrhythmias like torsades, depointes, all these things. So we are not at all using that. Other drugs, now there are newer drugs which are in the pipeline, but we are not using all these things.
Thank you, sir. Thank you, sir. Now the final part, I will to ask everyone what an MBBS student should know from pathology regarding malaria. We have covered almost everything. Can you just tell what are the points that they need to emphasize when they are preparing for their exam?
Yeah. So malaria actually either it can be asked as a structured essay question or as 2 or 3 short questions also. So structured essay question like a patient presenting with paroxysmal fever and maybe since it is from the pathology we may give like present with features of hemolysis, red colored urine or jaundice. So sub questions can be what is the likely diagnosis, what are the lab investigations, what are the peripheral smear findings and of course the life cycle of the parasite.
And even in practical, the slides of thick and thin smear.
Usually for the practical exam we keep only thin smear. Because the morphology we are picking up only in the thin smear.
Okay.
So for the practical exam we are keeping peripheral smear with mostly the ring form, and ring form is easy to identify. And also the Plasmodium falciparum. So that crescent shaped gametocyte is easy to pick up. So we'll be keeping that too as a slide, and anemia it's not. So these are actually the practical and the theory questions.
Thank you. Ma'am, coming to micro, what they should know, students.
So again, a structured essay we can have in microbiology. So the questions are usually what is the clinical diagnosis, and then what is the pathogenesis, what are the clinical features, the laboratory diagnosis of malaria, and then either a question on what are the other parasites that can be detected on peripheral smear, or maybe a question on the malaria vaccine.
Okay.
And prevention treatment.
Yeah, just when you said malaria vaccination, what is the status now? Anything that is good that is going to happen soon?
Yeah, there is now FDA has approved Muscarix, which is a vaccine against the circumsporozoite protein, which is it is meant for Plasmodium falciparum.
Okay, maybe high risk population will be children they will be targeting. Okay, Dr. Selekshu, can you just community medicine? Malaria is most important thing. Can you just briefly?
Yes, sir. In the chapter of malaria, if we start from the initial pages, the epidemiological types of malaria, like urban malaria, tribal malaria, that is a question. And then the determinants of malaria, that is the agent factors, host factors, environmental factors, that can be asked. And the host factors alone can be asked as a short note. Moving on, measurement of malaria, the eradication era indices like the annual parasite incidence, all those 5. Then prevention and control, as we discussed, the National Vector-Borne Disease Control Program, the active intervention measures, integrated vector management, all these can be asked as short notes. So every subheading in malaria,
is a question.
important, yeah.
Giri sir, any questions that they should
A question for MBBS students, actually it can be clinical features of malaria. Then second thing is pharmacological aspect. I already discussed how to treat malaria. Third one is the preventive aspects of malaria can be asked in medicine, because there are some drugs which can be given as prophylaxis against malaria. Like previously it was again chloroquine prophylaxis, then it came as mefloquine, now it is another drug. So newer drugs are coming. So that can be asked as a question for them. And last question will be tropical splenomegaly syndrome. That also asked as a short note. Again, madam has discussed that large spleen is very, very common in malarial parasite, chronic malarial infection. That is also asked in many question papers.
Okay. So with that, I thank each one of you for taking your time and doing an elaborate discussion of malaria. Thank you. Thank you all.
Thank you.